My name is Jeremy Myers. I work at University of Utah, Department of Surgery, Division of Urology. Today I'll be giving part 1 of a grand rounds talk on lower urinary tract trauma involving the bladder. Part 2 will follow and involves urethral injury, particularly after pelvic fracture. First we'll talk a little bit about the epidemiology of GU trauma. Trauma is the leading cause of death in patients age 1 through 44, particularly in the age groups between 15 and 34. Trauma, unintentional injury, suicide, and homicide are the 3 leading causes of death. This represents a significant burden of disease in the United States. In fact, greater than 150,000 people a year die of trauma in the United States. GU injuries represent a small number of injuries due to the protected nature of the GU tract. They occur in 0.5 to 10% of all significant abdominal injuries, and in all studies, kidney injury is the most commonly injured organ. In a nice study from Europe, investigators looked at injuries in patients that had sustained injuries from some type of motor vehicle crash. Motorcycles, cyclists hit by cars, pedestrians hit by cars, etc. They looked at the number of injuries. These weren't necessarily hospitalized patients, but probably patients that were evaluated in the emergency department. Of the GU injuries, kidney was a leading injury, but GU injury only occurred in 0.5% of patients injured in motor vehicle crashes. Now, these weren't all admitted to the hospital, so their injuries on the whole were probably average less than other series. Bladder injuries were very rare and occurred in only 0.04%. We looked at this at University of Utah in our paper published in the Journal of Trauma in 2013. We looked at a 15-year span at the 3 Level 1 trauma centers in Utah, including Primary Children's Hospital, University of Utah, and the IHC health system. There were 65,000 trauma admissions and 124 bladder injuries. This translated to 0.2% of all trauma admissions incurring a bladder injury, which was approximately 1 in 500 trauma admissions. So again, a very rare injury, even among severely injured patients admitted to the hospital after trauma. What about bladder injury and pelvic fracture? Pelvic fracture often accompanies bladder injury with blunt mechanism of injury. And just at University of Utah, there were approximately, on average, 120 traumatic pelvic fractures per year. And you can see the rate of bladder injury in red is quite low, between 3 to 6 per year. And so the rates of bladder injury per pelvic fracture is approximately 3 to 4%. Next, we'll talk about how to classify bladder injuries and the different types of bladder injuries. There is a grading system for bladder injuries developed by the American Association for Surgery and Trauma. This was a seminal paper in the late 1980s released by Dr. Moore, who's been associated with Denver General Hospital for his entire career. They released a paper which graded all organ systems in the body for trauma, and they applied this to the bladder as well. In bladder grading, you can see the grades are 1 through 5, which is true of any organ system, and they're graded by the location, extraperitoneal or intraperitoneal, and also by the size of the laceration. Practically speaking, the AAST grading system is virtually never used when you're talking about bladder injuries, but they may be used in some clinical studies, and also they're coded by this method in the trauma databases. Mainly when we talk about bladder injuries, we talk about the location, whether the injuries are intraperitoneal or extraperitoneal, and then the mechanism, whether the injuries are penetrating, for instance, a gunshot wound or stab wound, or blunt, which are often associated with pelvic fracture. Intraperitoneal injuries account for about 33% or a third of bladder injuries. When they're from blunt force trauma, they can be associated with pelvic fracture, which has a very high mortality, or they can be caused by other causes, such as an isolated blow to the abdomen while a patient's intoxicated and has a very distended bladder. The signs are blood in the urine, or hematuria, gross hematuria in this case, and then free fluid in the abdomen that's not explained. That could be found on a focused abdominal sonogram for trauma or a CT scan. In an intraperitoneal injury, the bladder is lacerated at its peritoneal surface, which is towards the dome of the bladder. This is a weak area of the bladder, and when you have a forceful blow, especially with a full bladder, the bladder can blow out in this location and cause urine to extravasate into the abdominal cavity. This surrounds the small intestines. Here you see a cystogram where the bladder is filled with contrast. You see that contrast coming out of the dome of the bladder, probably the lacerations over here, and it's very smooth and outlines the colic flexure here, or the colic gutter, and then it's smooth-walled and outlining the small intestines, a clear intraperitoneal type injury. On CT scan, which is a more common modality, here you can see contrast that's been filled into the bladder, outlining small bowel loops. You can see some contrast here behind the uterus in the pouch of Douglas, and you can see contrast coming up here surrounding the liver edge and the splenic edge. All free contrast within the abdomen. Extraperitoneal injuries are more common. They account for approximately 2/3 of injuries. They're almost always accompanied by pelvic fracture when they're caused by a blunt force mechanism. And urethral injury can occur with these pelvic fractures in about 10 to 15% of patients. That's very important to keep that in mind. The signs of this are gross hematuria, classically accompanied by pelvic fracture. Here's an example of a cystogram of an extraperitoneal injury. Here you can see contrast filling the bladder, and down low in the extraperitoneal space there's a clear laceration that corresponds to a bony fracture, which is almost always the case. And then there's this extravasation, which is wispy, as the urine or contrast during this study extravasates into the soft tissue surrounding the bladder rather than into the smooth-walled abdominal cavity. This is a injury that's confined to the space surrounding the bladder and the soft tissue surrounding the bladder, thus extraperitoneal. Here's a good example of an extraperitoneal injury. You can see a very bad pelvic fracture, the Foley catheter within the bladder, and then urine just extravasing through the abdominal wall connected via the fracture in the symphysis pubis. Next, we'll talk about imaging for bladder injuries. In the trauma bay, when you see this after placement of a Foley catheter, you can assume that the urinary tract is injured until proven otherwise. Gross hematuria is highly significant in a trauma patient for either kidney injury, urethral injury, bladder injury, etc., especially when it's accompanied by an X-ray of something like this. Here you can see a massive pelvic fracture with inferior superior rami fracture, diastasis of the symphysis, acetabular fracture, and then a large hematoma that's pushing the bladder out of the pelvis. This is referred to as the pie in the sky type bladder. So in this patient, obviously they need imaging for a bladder injury or other GU injury. And that's a patient that has gross hematuria after a pelvic fracture. Likely they have a bladder injury. Don't forget, patients that have blood at the meatus, you need to consider carefully whether they have a urethral injury, and they need to be evaluated for this prior to placement of a catheter or during placement of a catheter. But what about the patient that comes in that has microscopic hematuria? There's no gross hematuria and they have a pelvic fracture. Do they need to be imaged for an occult bladder injury? It's a very important question. This was quite a good paper published back in 2001 from multiple Makinich fellows looking at bladder injury. They looked at bladder injury at a number of centers that pooled their data. It was published in the Journal of Trauma. And then they also did a meta-analysis of previous published work. In their portion of the meta-analysis, they looked at gross hematuria and pelvic fracture and the risk of a significant bladder injury. And they found in the papers that the risk was approximately 30 to 50%. There was a range, but up to a third to even a half of patients did have a significant bladder injury if they had gross hematuria and a pelvic fracture. So these patients should be assumed to have a significant bladder injury unless proven otherwise. What about microscopic hematuria, however, in a pelvic fracture? Summing this data, they found that the risk was less than 1% of a significant bladder injury, and they concluded that you do not need to image microhematuria and pelvic fracture, and I believe this is also true. In penetrating injuries, however, the same rules do not apply, and the main reason for this, as I'll show you some data later, is that there can be microscopic hematuria associated with significant injuries, unlike blunt mechanisms. It's very similar to kidney injury, where with blunt mechanisms, often we see gross hematuria. With penetrating mechanism, often we have to assume, based upon the trajectory of the bullet, about probable GU organs that have been injured. So what are the diagnostic tests that can be used to assess for bladder injury? Patients can be explored operatively if they're being brought back for unstable hemodynamics and exploration of the abdomen. The bladder can be filled and a intraperitoneal injury can be easily diagnosed. If there's no obvious intraperitoneal injury and still hematuria, then cystoscopy could be performed to look for an extraperitoneal injury intraoperatively. A cystogram can be done, which is a plain x-ray filling the bladder and is still standard in many centers. But by and large, most centers are going to diagnose these injuries by either a dedicated CT cystogram or a trauma CT, which is a CT of the abdomen and pelvis with IV contrast alone. So how does a CT cystogram perform versus a regular cystogram? And there were multiple studies that were done around the inception of the CT cystogram that showed that it was quite sensitive compared and comparable to a cystogram. A CT cystogram is done by infusing approximately 300 to 400 cc's of contrast retrograde through the Foley. Then the Foley is clamped and a repeat CT of the pelvis is performed looking for injury. The advantage is that there's active distension of the bladder and the injuries are diagnosed very sensitively. The disadvantage is there's extra radiation and the test takes 5 to 10 minutes to perform in addition to the CT trauma. The advantage of the CT trauma and how it's done is during the scan, the Foley is clamped prior to the scan, and then depending on the urine output and the filtration of contrast, the bladder is distended. The advantage is one quick scan, less radiation, but the disadvantage is there's passive distension and it may be very poorly sensitive depending on how distended the bladder becomes. Some studies have shown quite a bit of limitation in the CT trauma. This was one study of 24 injuries. 15 of the injuries received a CT scan and they all received a cystogram. And unfortunately the CT trauma had very poor sensitivity and specificity of 50 to 60% in some cases. These are the types of injuries that can be easily missed. This is from a case report from San Francisco General Hospital. And above you see the CT scan, and then below you see the same patient having a CT cystogram where there's a small extraperitoneal leak. Now, this may not be clinically significant, this small extraperitoneal leak, but assessing patients, the extent of their injury, is essential to safely managing the injuries in a conservative manner. And so that's an argument for doing the correct test and making the correct diagnosis. Consensus statement was released in 2004 on GU trauma, and in essence paraphrasing the consensus statement, very strongly states that active distension of the bladder is essential to adequate diagnosis of bladder injuries, either with a CT or a plain cystogram. Next, we'll be talking about management of these injuries and some about our data at University of Utah. Intraperitoneal injuries arising from blunt trauma need to be repaired always. The reason for this is these injuries often involve very large lacerations and very large blowouts of the anterior bladder or the dome of the bladder. These patients have urine that's extravasating into their peritoneal cavity. The urine is very caustic, will cause their creatinine to rise, and may cause a urinoma or infection. In patients with extraperitoneal injury, the management can vary from catheter drainage to surgical repair. It's not very well defined who needs surgical repair among this group. Some of the indications for repair are hematuria that's persistent and causes problem or obstruction of the catheter, bladder, neck, or prostate injuries. For whatever reason, these don't tend to heal well, independent of surgical intervention. Bony fragments that project into the bladder cause chronic fistula and can lead to osteomyelitis and chronic urinary extravasation, persistent urinary extravasation after catheter drainage. And then a relative indication is other surgeries such as orthopedic or general surgical procedures. It may be wise to repair the bladder at that time depending on the nature of the injury. Here you can see a fairly innocuous extraperitoneal injury. This is a type of injury that will heal very rarely with catheter drainage alone. You can see that the bladder has a good capacity and there's a slight amount of extravasation. If you contrast that with an injury like this, here's extraperitoneal and intraperitoneal injury, massive injury, and clearly an injury like this is not going to do very well if it's left to catheter drainage alone. The injuries are repaired by approaching the bladder along its peritoneal surface. A large anterior cystostomy is made along the peritoneal surface. This allows approach of the bladder from the inside, leaving the pelvic hematoma intact. Here, the anterior cystotomy reveals a large extraperitoneal injury, which can be repaired from the inside with a full thickness stitch. Then the intraperitoneal component or the cystotomy can be closed with a two-layer closure. What about penetrating injuries? I just want to present our data from University of California, San Francisco, and the San Francisco General Hospital. This is a project from Dr. Ben Breyer, Nadia Sinman, and Jack McInich, which we assembled the data for when I was a fellow at San Francisco General Hospital. We looked at 39 patients with a gunshot wound to the bladder, and these patients are significantly different from blunt bladder injuries, and that's the reason this is worthy of discussion. The patients only had hematuria in 70%, so very similar to kidney injuries. Hematuria is not a completely accurate predictor of a bladder injury. Buttock wounds were common, and a very important component of this is that the patients almost universally had an entry-exit wound to the bladder. And so if you see a large bladder injury from a gunshot wound, there's likely an injury opposite it, representing either the entry or the exit wound. Bowel injury was entirely common, occurring in almost every patient, and many of the patients had rectal injury and required fecal diversion. Another important component of this is 100% of the injuries were managed operatively. So what about University of Utah data? And I want to present specifics from the paper we published in Journal of Trauma in 2013. We looked at 15 years of the trauma database from all level 1 trauma centers, as I mentioned earlier. These were Primary Children's, University of Utah, and IHC Health System. There were a total of 124 bladder injuries out of the 65,000 trauma admissions during this time period. The characteristics of the bladder injury were very similar to other large series published within the literature, mainly in the 90s and 80s. The mean ISS was high and was 26. The vast majority of the patients were injured by blunt mechanisms, 90%, and approximately two-thirds of the patient had extraperitoneal injuries, very similar to other series. The most common concomitant injury was a pelvic fracture, occurring in 80% of the injured patients. Another very interesting component of the finding within the demographics of this patient population is that we found that intraperitoneal injuries, the rate of death was 22% versus 4% within extraperitoneal injuries. This represented an odds ratio of 12.4-fold higher risk, which was statistically significant. This has not been expressed in a lot of other studies, and I think this was because the vast majority of these patients had concomitant pelvic fractures. You can see patients with intraperitoneal injuries from a single blow to the abdomen while intoxicated. These patients don't have a pelvic fracture, and these injuries can be fairly innocuous and the sole injury of the patient. These patients obviously are in a different demographic for intraperitoneal injury. A primary focus of the paper was upon the imaging that was done to diagnose these injuries. We found that with it in the University of Utah and other trauma systems, we were very poor at diagnosing these injuries by recommended methods. 81% of patients were diagnosed by some imaging method rather than operative exploration. And the vast majority of these patients were diagnosed by a CT trauma, which has the limitations, as I previously mentioned, of not actively distending the bladder. And there were 13 missed injuries within the series. Did this lead to morbidity? It absolutely seemed to, because there were a total of 5 laparotomies that were done for what was assumed to be intraperitoneal injuries based upon trauma CT scans rather than a CT cystogram or a cystogram that turned out to be extraperitoneal injuries only. These patients didn't require laparotomy for other reasons, and so these 5 laparotomies really represented unnecessary surgeries, at least in some of the cases where the injuries could have healed with catheter drainage alone. What about conservative management of extraperitoneal injuries? This is a chart of the studies that I found on management of extraperitoneal injuries with conservative methods. The total number of patients managed conservatively was about 114 out of all these studies, which was 56% of the patients across the studies with extraperitoneal injuries alone. The complication rate was approximately 14%, and these mainly consisted of persistent urinary extravasation, although certainly many of the patients had pretty severe complications, including ileoconduit urinary diversion and requiring subsequent surgical closures. If we look at our data pre-2009, which was the arrival of a dedicated trauma urologist, we treated a very high number of patients conservatively, 71% as opposed to 56%, the overall rate within the literature. And there was a high rate of persistent leak of 18% in these patients treated conservatively. We looked at follow-up data after 2009, which was the advent of having a dedicated GU trauma focus, as well as imaging protocols. And we looked at the rate of operative intervention for extraperitoneal injuries and the rate of leak. One important component is that the injury severity score increased in patients after 2009, so these patients were more severely injured. We managed less patients conservatively, so there was a higher operative rate. And we were gratified to see that the persistent leak rate was much lower It dropped from 18% in conservatively managed patients to 0. In regards to patients with the higher ISS scores and the greater severity of injury, it's certainly been our impression that patients are surviving worse and worse overall multi-systems trauma. This is due to advances in general surgical management and damage control surgery, as well as advances in an understanding of the physiology of shock and how to manage patients with multi-systems trauma. This is a case we recently published in Urologic case reports of a patient that had an ISS of 43, so through the roof, a 62-year-old man that was admitted after being struck by a bus. The patient had severe extraperitoneal and intraperitoneal injury. These were repaired at the time of abdominal exploration shortly after his injury successfully, but at day 7 these repairs broke down and he had massive extravasation. In fact, he had urine leaking out of his external fixator pins. Due to this severe extravasation and the severe overall injury pattern, we elected to ligate the ureters to prevent urine from leaking into the pelvis. We then placed percutaneous nephrostomy tubes. The patient was dependent on percutaneous nephrostomy tubes over the course of the next 9 months. So at 9 months, we were able to repair the patient. We performed transureterostomy and psoas hitch and reimplantation of the left ureter into the dome of the bladder. The reason we did the transureterostomy was to make adequate space for the general surgeons to reconnect the patient's sigmoid colon to the rectal stump. He currently voids well without obstruction of his kidneys, and he has successful reversal of his colostomy and a good quality of life. This type of case becomes more and more frequent, and out-of-the-box thinking is needed for management of these massive pelvic traumas as patients are surviving greater and greater injury patterns. The next thing I want to talk about is our imaging algorithm for blunt trauma. We developed this algorithm to facilitate imaging in patients with gross hematuria and blunt trauma. So basically, if a patient has gross hematuria after blunt trauma, the first question we ask is if the patient has a pelvic fracture. If the patient has a pelvic fracture, we assume that the majority of the problem is likely a bladder or urethral injury. If the patient has pelvic fracture and gross hematuria, you can see that the flow is down towards a dedicated CT cystogram. If there's no bladder injury on the CT cystogram, then we consider evaluating the urethra. If the patient does not have a pelvic fracture and there's gross hematuria, we assume that the hematuria is likely coming from a kidney injury. And then the patient has a trauma CT scan. If there's significant kidney injury, then they have delayed kidney images. If there's no major kidney laceration, we consider a CT cystogram, as the patient may have an intraperitoneal bladder injury without pelvic fracture. If the patient has blunt trauma and there's no gross hematuria, then the patient has a standard trauma CT depending on mechanism. If we identify a significant perirenal hematoma or injury or fluid around the kidney, then the patient has excretory kidney images performed. In penetrating trauma, gross hematuria may not be a significant predictor of significant injury, and patients may only have microscopic hematuria. If there is any element of hematuria, then we look at the location. If it's in the abdomen and thorax, then patient needs to be evaluated with a trauma CT. If there's significant kidney injury, then they need delayed images to the kidney. If the location is within the pelvis, buttock, or lower abdomen, and there's significant hematuria or microscopic hematuria, then patients need a CT cystogram to evaluate for significant bladder injury. So we looked at the imaging after institution of this GU trauma algorithm, and we were gratified to find a great improvement. Looking at our process improvement paper, we found abysmal results. The majority of patients were evaluated by a CT trauma, and only a quarter of patients had appropriate imaging with a cystogram component, either CT or plain cystogram. We contrast that to after institution of the algorithm, and we found a 96% compliance with obtaining a CT cystogram or a plain cystogram, and really 100% compliance with recommended images, because the one patient that wasn't imaged in this group underwent operative exploration, and that's a perfectly acceptable way of diagnosing these injuries. So we found a dramatic improvement in our ability to detect the injuries, and most importantly, the rate of missed diagnoses or mistaken diagnoses dropped to 0 in that time frame. Where do we go from here? A study now is ongoing that University of Utah has been heading through the American Association for the Surgery of Trauma and the Multi-Institutional Studies Center. This is a multi-center study of bladder and renal trauma. We have approximately 26 centers that are interested in inputting data, and we hope to assemble this data as well as the relevant radiologic studies. Our hope is to find a better method of grading patients with bladder injuries that might benefit from operative repair versus those that can be managed successfully conservatively, and identify situations where patients need to be managed operatively, for instance, when they're undergoing orthopedic stabilization and anterior plating of the pubis. This should reveal very interesting results in the next 2 to 3 years in both bladder and renal trauma. In conclusion, gross hematuria and pelvic fractures almost universally associated with extraperitoneal bladder rupture. The combination of gross hematuria and pelvic fracture predicts a bladder injury in about 30 to 50% of cases. Urethral injury is very common with this scenario and occurs in about 15% of patients. And a CT trauma scan alone is inadequate and leads to missed and incorrect diagnoses, and in our series led to 5 apparently unnecessary laparotomies for a mistaken diagnosis. The death rate in patients with intraperitoneal injury is much higher than extraperitoneal injury within our series. Imaging algorithms in trauma care increase adherence to recommended strategies and decrease the rate of missed or mistaken injuries. Involvement of a dedicated urology team may decrease complications like persistent urinary extravasation and may allow better stratification of patients that would benefit from operative versus conservative management. Thank you very much. I hope this lecture has been informative.